I'm a second-year internal medicine resident at HCA Kendall Hospital. I'm the first author of this case report titled Lingering Shadows and Unveiling Candida albicans-driven Osteomyelitis and Psoas Abscess despite intensive antifungal therapy. This case involves an unforeseen instance of osteomyelitis due to Candida albicans occurring despite extended antifungal treatment. Let me describe what took place in this intriguing case. A 61-year-old male who presented to our facility with a primary complaint of intractable lumbar back pain with past medical history notable for multiple urological procedures performed several months prior to address a large right renal calculus and urethral strictures. These procedures were complicated by an episode of candidemia, which was treated effectively with micafungin and subsequently discharged from the hospital on 400 milligrams of daily fluconazole to complete 4 weeks of therapy. Unfortunately, shortly after discharge, patient was readmitted with new symptoms including vision loss and worsening back pain. During this admission, he was treated with intravenous fluconazole for 6 days and was discharged on an intensified dose of 550 milligrams daily fluconazole with follow-up arranged with ophthalmology. Ophthalmologic evaluation revealed candida growth near the macula. As a result, he received intravitreal voriconazole injections and his antifungal therapy was switched to voriconazole. The treatment aimed to resolve his macular lesions, followed by an additional week of therapy. While his visual symptoms improved, his back pain persists. Initially, the back pain was presumed to be musculoskeletal. The patient underwent physical therapy and pain management with partial success. However, the pain recurred soon after completing therapy, leading him to seek urgent care, where lumbar spine imaging showed no significant musculoskeletal issues. Patient returned to his primary care physician, who ordered an MRI of the lumbar spine. Due to severity of the pain, he was referred to the emergency department, which CT imaging revealed L1 vertebral erosions and right psoas muscle thickening, suggesting early ascites. Subsequent MRI showed a right psoas abscess and osteomyelitis of the affected vertebra. Initial tests, including HIV screening, urinalysis, and blood cultures, were negative. A bone biopsy and an abscess aspiration revealed pan-sensitive Candida albicans. The patient was started on empirical antifungal therapy, which was later de-escalated to micafungin based on culture results. He was discharged on a peripheral inserted central catheter and a plan to complete another 8 weeks of antifungal therapy. This case highlights a rare and severe complication of Candida albicans infection, especially osteomyelitis and a psoas abscess. Despite appropriate and extended antifungal therapy with micafungin and fluconazole, deep-seated infections like this sometimes remain challenging to manage due to potential limitations in drug penetrations into bone and deep tissues. This literature suggests that standard antifungal treatments may not always achieve adequate concentrations in these areas, leading to persistent or recurrent infections. This case emphasized the need for tailored treatment strategies, potentially including prolonged antifungal therapy and surgical intervention, as well as the importance of a multidisciplinary approach involving both infection disease specialists and surgeons. In conclusion, what makes this case so unique is the incidence of an abscess and osteomyelitis following an intensive and prolonged antifungal therapy. This case underscores the complexities of treating deep-seated Candida infections and highlights the importance of a comprehensive multidisciplinary approach to improve patient outcomes in such challenging scenarios. This brings my presentation to an end. Thank you for listening.